So welcome everybody. And what I wanted to do today is to, hopefully we'll have Ezekiel join us from Tanzania. It's challenging. But if not, we're just going to talk a little bit about the history of the Phil Simon Clinic Tanzania project, because I know some of you are intimately familiar with it and some of you are not familiar with it at all. And so I'd like to just sort of talk a little bit about how this all happened, how we met Ezekiel, and what are our mission statements and so forth. Just to save some time, if he joins in the next couple of minutes, I just want to give you a little bit about his background. Ezekiel likes to refer to himself, and I think it's a good moniker, as our firstborn, because he was our first scholar to receive a full scholarship to attend medical school. And I'll tell you the story as we get kind of deeper into this. He received his diploma as a clinical officer in 2003 from the Coloma Clinical Officer Training College. Clinical officers are really the backbone of healthcare in East Africa. They're comparable to a nurse not to a nurse, more to a physician's assistant, I would say. But they really are the main engine, if you will, of most of healthcare around the world. It's not just typical for Tanzania. So he received his clinical officer title in 2003. And he went to work at the Uponi Health Center in Arusha, and that's where we met him. After we decided that we wanted to put him through medical school, and I'll tell you the story in more detail in a minute, he attended the International Medical and Technological University in Dar es Salaam, where he completed his bachelor's in medicine and surgery. That's comparable to an MD in 2011. He then went on to complete his residency training, which is quite rare in Tanzania to proceed after you get your general practitioner's license to residency, and he went into internal medicine and received a master's of medicine, internal medicine at the University of Dodoma in 2016. In 2019, he was awarded a scholarship by Agostino Gemelli Hospital in Rome, Italy, where he completed a fellowship in gastroenterology and subspecializing in upper and lower endoscopies. And he is actually one of the very few trained Tanzanians who can perform upper and lower endoscopies in his own country. He served as the director of the internal medicine section at Benjamin Mkapa Hospital and has been a professor of medicine at Dodoma University from 2016 to 2020. He's currently a professor of internal medicine at Kilimanjaro Christian Medical College in Moshi, which is about 90 minutes north of Arusha. And he has recently been appointed as a program officer in the Ministry of Health for the Republic of Tanzania. He is in the Department of Neglected Tropical Diseases, which I think is a fabulous title. So, so that's where he is right now. And so I'll just kind of proceed here until I get the high sign from somebody that he's here. So, however, I need to be able to advance the slides here. How are we doing this? What's going on? There we go. Okay. So I think this is sort of an obvious statement, but all of us know this very intimately now, the importance of global health, that what happens in other countries can certainly affect us, even if it's across thousands of miles and oceans, and that it behooves us to recognize our vulnerabilities and our unity as one planet, that global health is really not divided into them. There's only us. And that includes the us is not just humans, but animals and plants and the planet in general. And I think that has really been demonstrated dramatically and to some degree tragically over the last 3 years during this pandemic. And many of you have seen this slide before, where I talk about sort of all the different elements of global health, and it's many, many different things. And this is something that we keep in mind as we proceed in our project in East Africa, that it is not just about medical care for human beings, but it's all about different types of research, equity, stewardship for animals and wildlife, the ability to utilize and design and devise novel devices that can be used in underserved areas, and to really bring the planet together in a unified fashion so that we can do better the next time we have a pandemic, which could be tomorrow. But also, more importantly, to recognize the problems that we have in healthcare all around the world, in our country and in other countries, and the challenges that we face as we move forward with our ability to diagnose disease, treat it, and its implications. So Africa has always borne the burden of global HIV disease. It's really critically important. They were the first to be impacted by the human immunodeficiency virus, and it spread very quickly. And it has been the area that has been the most impacted, I would say, by HIV during the HIV pandemic. In part because of the limited access to both testing and medications for a long part of the HIV pandemic. That has changed dramatically, and I'll talk about that in a second. But it has really been a significant health issue throughout the world, of course, and in many underserved countries, but particularly on the continent of Africa, and Tanzania is no exception. They really have had a long battle with HIV. And this is really germane to why we ended up starting our project there in the early 2000s. We were in the process of beginning to have some access to antiretroviral therapy that was very effective in the United States and really controlling the disease, controlling the spread of the disease. And so as we had those opportunities in my own clinic, the Phil Simon Clinic at Huntington Hospital, we really recognized that there was a need around the world and that perhaps we could share some of our knowledge, if not medications and other things, with countries that really had very little. And that's how we ended up sort of launching this project. This is a slide from the most recent retrovirus meetings that were in Seattle, this is from PEPFAR, the President's Emergency Plan for AIDS Relief in Africa, which was started by George W. Bush. And what we could see is that prior to HIV, that the lifespan throughout much of Africa was actually increasing, that we were beginning to control things like malaria to some degree, although it still continues to be a challenge, tuberculosis, and perhaps most importantly, maternal child morbidity and mortality, especially postpartum infections in women that are a very leading cause of death. So while those sort of things, polio would probably be in here as well through vaccinations, but the lifespan in Africa was going up, including Tanzania. Uganda was a little bit of an outlier, but that may have been some of the political stuff going on there with Idi Amin and so forth. But then you can see what happened by the about 1990, when HIV started raging across the continent, and the lifespan started going down. Not only did it go down, but it went down to what it was before 1960. And this was very similar. This is Kenya, Botswana, and Zimbabwe. It certainly was also true in Tanzania. So very significant impact, but it started, the lifespan returned with the deployment of effective antiretroviral therapy on the continent of Africa. And that allowed the control of the disease in people who were infected, but most importantly, it also prevented the transmission of disease, because we know that individuals who have fully suppressed viral loads are no longer infectious. And so you can see that the lifespan has increased almost to where we were sort of in the early successes of the 1990s, thanks to PEPFAR and to other agencies which provide crucial antiretroviral therapy for people with HIV in Africa. This is important because this is how we got started in our own project there, but also it is definitely a representative disease of many things that are going on in Africa, that we have to use this example that equity in distribution of medicines and important therapeutics, whether it's for HIV or SARS-CoV-2 or tuberculosis or malaria or cancer or diabetes, that it helps all of the planet if people that wouldn't have access to those medications do. And so, inspired by our successes in HIV care at Huntington Hospital's Phil Simon Clinic, we wanted to address some of the devastating problems that were happening in sub-Saharan Africa. And so we established our nonprofit through the hospital at that time, under the umbrella of the hospital, in 2001, and took our first trip in 2002. And for those of you that aren't real familiar with Africa, this is Tanzania is in East Africa, just south of Kenya, north of Malawi. To the west is the Democratic Republic of Congo. Rwanda is up here. It's a very large country in East Africa, and a very relatively not developed, because it didn't benefit from some of the colonial stuff, whether that's a benefit or not, that was in Uganda and Kenya. But it has been a very relatively stable country, thanks to Julius Nyerere, who was the first president of Tanzania. And it was very inclusive in terms of the tribes that were governing the country. And our project is located predominantly in Arusha, which is right up here in the north part of Tanzania. Arusha is famous because it's kind of at the foot of Kilimanjaro. And it also is the starting point for many safaris. We have the Serengeti, Ngorongoro, Lake Manyara, all out here in easy access. So it's an area that's known by a lot of people who go on safari in Tanzania, but that's where we work. We also have a project out in the Serengeti as well. And that's where we met Ezekiel. So the United Republic of Tanzania gained its independence in 1961. It's about 53 to 60 million people now, comprised of about 120 different tribes. It's a very poor country. The per capita gross net GDP is about $768 annually. It's largely an agrarian economy, but tourism is a critical part of this. There are natural resources in Tanzania which are being utilized, I guess would be the politically correct word, but it has possibilities, but that has to be balanced against the importance of maintaining the sort of sanctity of some of the really incredible game parks and so forth that are throughout Tanzania. Again, Tanzania is one of the poorest countries in East Africa, and if you compare the GDP with the United States, these statistics are a little bit old, but you can see the dramatic difference. Even South Africa is substantially higher than Tanzania. So they really are challenged by economic difficulties as well. And so it's not surprising that there's some really challenging health problems. A lot of the poverty and lack of access to medications and good healthcare and the enormous shortage of healthcare workers has really impacted the life expectancy of Tanzanians, which is substantially shorter than Americans. Of course, we know recently that the American lifespan has dropped a little bit, and we're still actually fairly low in the list of life expectancy. But the Tanzanians really have a substantially shorter lifespan, at least in the past. So we went in 2002. This was our first team, a pretty small team. This was really sort of an exploratory trip. And since then, we have now been returned with 11 different medical, surgical, veterinary, laboratory, social work teams over these last 21 years. And if you asked me 21 years ago if we were going to still have this project in East Africa, I probably would have thought, well, maybe the last 10 years or so. But it's been very, very successful and inspiring from both the people that go to Africa to give generously of their resources, from the amazing donors to our project, and perhaps most importantly, by the Tanzanians that we have come to know and love and work with, because it is truly a remarkable country with remarkable people. So the project itself, in terms of our mission statement, has gotten much broader than just HIV care. We certainly want to provide comprehensive, compassionate healthcare to underserved in Tanzania through a culturally sensitive and collaborative partnership. And collaboration is really the important thing here. This is not us going over there and telling them what to do or how to do it. It's us rolling up our sleeves with our Tanzanian colleagues and addressing their particular healthcare needs and what we can do, often just in a small way, to make a difference in their healthcare. We want to provide and create a global forum for multidisciplinary interactions that will enhance our understanding of the diseases that challenge countries, not just Tanzania, but also our own country, and to create a rich and reciprocal academic environment that promotes good medicine and academic and global stewardship. And that's, again, it's just a very collaborative project where we have an opportunity to work with amazing people and understand what their challenges are. When we go, we do adult internal medicine, we do pediatrics, we have many medical subspecialists who go with us, and we spend 2 weeks there helping patients in medicine clinics, and then we have a robust surgical program. We take with us pharmacists and limited diagnostics. Working in East Africa is always a challenge because we have to develop things that are very robust, that you can use out of the back of a Land Rover. And so it limits our laboratory techniques. Whenever my house staff go over there, the first thing they want to know is, where is the CAT scanner? And of course, there is no CAT scanner because there's no electricity in the clinic that we work in. They do have access now to some more sophisticated radiologic imaging, but where we work, it's quite limited. Oops, there's some music going to come in here. We also have a surgical program that is quite robust and works very well with our surgeons doing corrective surgeries for orthopedic and plastic surgeries. We have a robust graduate medical education program, training medical and surgical residents. And I am going to have to turn off that music. Sorry about that. And then we have social work outreach support groups. We do art and music. Home visits are all part of our kind of building the fabric of the project, getting to know the people in Arusha. It's really a remarkable experience to go into their homes and work with them. And a lot of our patients are HIV positive for the social work outreach programs, and they can do remarkable things with very limited resources. The Tanzanians were very quick to adopt patient-run support groups and patient-run outreach to people that couldn't get food, or making sure that people can get their medications even if they can't get to the clinic that provides the antiretroviral therapy. So a lot of the support that's done in these countries is really grassroots stuff from people that are either have the disease themselves or are growing out of the community themselves and really trying to provide care. We try to be very academic and tap into the enormous talent of the people that go with us, whether they're nurses or physicians or researchers or veterinarians, and doing academic outreach, working with our colleagues in the hospital setting at St. Elizabeth Hospital where we work, and then also in the clinics. And this is Dr. Seth Vaccaro, one of our dermatologists, he's an expert on leprosy, and gave a really just fascinating lecture on something that is quite common in Africa, not as much in East Africa, but it's certainly a significant problem. And then Dr. Jonathan Pye, who's a surgeon from England, who was running the suture clinic to teach the surgical residents there some special surgical techniques. And one of the overriding things that we find really very inspiring is the whole concept of One Health, that addressing global health requires the input from all kinds of professional people, whether they are medical people or laboratory people or research people or public health people or politicians, whether they're scientists, zoologists, mammalogists, virologists, whether they're food safety people. And so it's really important that we all talk to each other, because often other types of professionals, for example, veterinarians, may have information that's helpful for medical doctors and vice versa. On some of our trips, our medical doctors have been able to teach classes to the veterinarians on different types of surgical techniques that would be helpful for removing a tumor from an animal. Our veterinarians have been very helpful with our medical doctors to talk about the importance of controlling rabies and good animal health. And so it's important that we have this conversation, not just with the professionals that go to Tanzania, but with the Tanzanians themselves and their professionals, their veterinarians, their medical doctors, their surgical doctors. And I think that building that kind of robust, diverse, under one umbrella kind of program is very helpful moving forward with global health issues. We have, as I mentioned, a robust veterinary service, and we have both small and large animals that we work with. Last time we were there, we spayed or neutered 150, not we, but veterinarians spayed and neutered 158 doggies. This is kind of an interesting little doggy operating table apparatus. And per the request of Jane Goodall, we did a donkey clinic with our equine vets that was very successful, teaching the locals how to safely and humanely use their harnesses on the donkeys so not to create sores, how not to overload them with too much weight so that they get sores on their backs, how to take good care of them so that they live longer, and continue to help them carry water and wood and so forth so their wives don't have to. Research is really a significantly important part of moving countries forward, and there's been a big push in the scientific community around the world to really incorporate local communities and local institutions in research, and we've tried to do that in our program as well, with some early studies on looking at animal-human diseases, and then also testing novel devices. This is Dr. Marie Cheta, who's one of our previous board members and team members, who's looking at a device that can actually, without doing an echocardiogram, can measure the function of the heart. This is Dr. Emily Green, one of our veterinarians that was out on the Serengeti. We're taking samples from local cattle to look for the presence of brucella, and then also comparing that with blood samples of the herders to see the crossover between brucella and between humans and animals. And so there's lots of really creative, fascinating projects that we can come up with that we're participating in, and inspiring our young people in both in the United States and in Tanzania. And Nature, the very prestigious scientific magazine, in the last week's journal, really put forth the critical importance of including research and integrating that into countries that don't have robust research programs. So Tanzania is really making an effort to do this, and I think it's a significant impact it will have a significant impact in improving their healthcare. So getting to the crux of the matter, and I have the sneaking feeling that Ezekiel is still not on. Am I right, Ariel?
Yes, I haven't seen him pop on, and I sent him a message.
I don't think we have him on here yet.
I don't think we have him on yet.
Is our scholarship program. And as I mentioned, Ezekiel was our first. This is Dr. Ezekiel Moirana here was our first. This is Dr. Rebecca Gertie. She just graduated from medical school a couple months ago. And this is Jacqueline Winifred, one of our nurses who's in the process of getting ready to go to midwifery school. She's already an RN. But we now have 8 new scholars, and I think you've met many of them. You're going to hear more about them later in the year and have heard them at some of the presentations. And this is really, I think, perhaps the most powerful and impactful part of our project, because when you educate young people and inspire them, they go out and change thousands of lives. You can build a clinic with bricks and mortar, but it falls down or is washed away or is taken over by goats or is knocked down by a hurricane or a tornado or an elephant. But humans that are trained to do something and go out and provide healthcare, that's very, very impactful, not just in what they can do for their patients, but the inspiration that they provide for other young people to follow in their footsteps. And all 3 of these individuals have done that. And I'm sure that our other scholars will continue to carry that on. As we've talked about previously, the shortage of healthcare workers in many countries around the world, but particularly in sub-Saharan Africa, is just astronomical. And you compare the number of doctors per patient per 1,000 population, United States versus Tanzania, is huge. And of course, this is just across the United States. We have a shortage of healthcare workers in the US right now, especially nurses, but also doctors, but it's nothing compared to Tanzania. And so by educating one physician or educating one nurse in Tanzania, you really can have an enormous impact on many, many people in many, many communities. And it does require education, it requires support, and you have to continue to support these folks. Residencies, they are not paid for. They don't get paid when they're in a residency, unlike our country. And so we have to cover their costs while they're in residency. It's important that they have that kind of specialty training, although we know that general practitioners are also very, very important. We're just delighted that our most recent medical doctor is a woman, because female physicians are still uncommon in East Africa. And I think, again, she is already has inspired many, many young people, and she has chosen to pursue a career in obstetrics and gynecology, of which there is enormous need for really well-trained doctors to really decrease the mortality and morbidity that we see with a lot of those kind of diseases. So, any sign of any Tanzanians? I fear that the Wi-Fi has done us in here. Oops. So let me tell you the story of Ezekiel. It's a very good story, I think. This is Uponi Clinic. This was the second clinic that we worked in. This was the second year. The first year we were with some British physicians in a clinic that was for wealthier Tanzanians. It was kind of our first dip in the water. Those physicians actually moved on to Israel. And so we didn't have that connection anymore. And it wasn't quite what we were looking for. It was not the populations that we were looking for. And so through our partnership with Global Partners for Development, which is another nonprofit that actually got us to northern Tanzania, we were able to meet Dr. Solomon Oliganuri, who was at that time in the Ministry of Health of Arusha. And Dr. Solomon had a clinic that he ran called the Uponi Charitable Medical Center, which serves individuals in medicine. Medical care in Tanzania is not free. You have to pay out of pocket because nobody has any insurance. But he made an effort to really reach out to the underserved community. And when we became associated with him, it was an opportunity for us to really have a nice encounter with people that really needed our services. And so these were sort of our first clinic venues, and many of you remember these. very early days. But this is the venue where we met Dr. Moirana. And it was in 2006, and this is Ezekiel here. I was going to make some comments about how thin he was here, but he's not on here, so I won't appreciate it. So hopefully he'll come on at some point. Here he is with Stratos Christianakis, who was recently just retired from being our graduate medical education director, but he was at the time a resident, and he was our second resident to go with us to East Africa. And he and Dr. Moirana became good friends and worked in the clinic. And I had never met Dr. Moirana. He wasn't Dr. Moirana at that time. He was Ezekiel because he hadn't gone to medical school. But I was very impressed with him. He was very, very intelligent, very bright, very motivated. And this picture is kind of interesting because it was at this moment we were talking about some medical thing, and some of us were eating lunch. And this is Dr. Kevin Tyson, one of our physicians who went with us, and of course Jody Casserly, who helped establish our home-based care project. Eliud, and this is Ezekiel. But I was very impressed with both of these young men, and I wanted to know what they were going to do. And they both expressed that they wanted to become physicians. And I thought, well, that would be a great thing. I really encourage you to do it. But I had no idea, whether we would be able to do that or not. But it was sort of put a bug in my head, and we began to think about what we might be able to do. And it was actually at this lunch, at this perhaps moment when I'm pontificating about something, that I thought about that. And we worked very closely with Ezekiel in particular. He and Stratos became very good friends. And even though Stratos is looking a little skeptical here, they really have been continued to enjoy a nice friendship. And we had, like we did in our Phil Simon Clinic, we had multidisciplinary clinics where we had social workers like Jody Casserly here with us, with the physicians, to discuss difficult problems. Ezekiel acted as both clinician and translator. And here he is with the team, sort of having some fun and getting ready to kind of, that was, I think, our last day and we were in Yuponi. And here he is with Stratos doing some sort of cool gesture of something. I don't know what that was about, but they were having a nice time. So let me tell you about Judah. When I came back from that trip, Judah White was one of our second-year residents, just a remarkable man. He'd been an attorney, and he decided that he wasn't really having enough contact with humans, and so he chose to be a physician. His dad was a physician. He was a gastroenterologist in West LA. And so Judah went to medical school, and then he came to our residency as a resident. Very, very kind, compassionate, intelligent, just a lovely, lovely person. And after our very first trip, I was attending with him on the wards, and he had this kind of nagging cough that we finally had to explore, and he was diagnosed with Hodgkin's lymphoma at the age of, I think he was 32 or so. That's a fairly treatable disease in young people, but he didn't do well, and he was at City of Hope. They took wonderful care of him. He got a bone marrow transplant, but he just could not get over it, and he passed away. And when I came back from the second trip, after meeting Ezekiel in the Yuponi Clinic, and then also in the orphanage that we that he came to work, he stopped working at Yuponi, and he was kind of floundering, trying to figure out what he wanted to do. And so he went to this orphanage outside of Arusha. And when I'd come back from the trip with talking with him, Judah's mom called me and said that there was a small annuity and they would like to donate it to the Phil Simon Clinic. And I said, I think I know where we should send that money. And so we went back the next year, and Ezekiel was still at the orphanage, and I had him come out to the lodge where we're staying at. And I said, if you can get into medical school, we will put you through medical school. And what's remarkable about this story is that these two young men, about the same age, but very, very different backgrounds. Judah is, from West Los Angeles and highly educated, and and lives in California. And Ezekiel is a Tanzanian. He's one of 12 children, and grew up in quite not complete poverty, but quite poor. But they both have the same personality, the same character, the compassion, the curiosity, the funny senses of humor, a vibrance. And I thought this was such a great legacy for Judah, that Ezekiel picked up the talent, sort of the baton, and carried it forward. And he has had a very close relationship with the White family since that time. I don't know if Judah's mom is on tonight, but And he's done this many times, not just with the White family, but with some other families where he established a remarkable relationship. So I think this is a very nice and appropriate story for how Ezekiel became part of our project. This was his graduation day, very proud moment for all of us. And then this is when he was in Rome doing his fellowship in gastroenterology. And I think that, again, it's a very rare event for a physician in Tanzania, a Tanzanian trained physician, to become a specialist. And so he currently is at, as I said, one of the very few endoscopists in Tanzania, and a very skilled endoscopist. This is Dr. Guido Costamagna, who was the head of the European Gastroenterologic Society. Very, very nice man. He's the head of Gemelli Hospital's GI department, very prominent person. He absolutely loves Ezekiel, and as did all the nurses, and continues to have contact with him, I believe. And so Ezekiel has really become a very distinguished endoscopist. He was influenced by two of our fantastic team members, Dr. David Schulman and Dr. Peter Rosenberg, both of whom are GI docs, and who have continued to be in contact with Ezekiel. And when he came to the United States to do a month with us at Huntington Hospital, he met several other GI doctors, including Dr. Isaac Bartley, who's also been a big influence for him. So this is quite an astonishing achievement for him to do that. We were lucky enough to have him over here a few times, and he'll, I'm sure, be back again. And this was up at Mammoth, where he shed his medical mantra and became a mountaineer and saw snow for the first time that he could actually touch instead of just on the top of Kilimanjaro. So, so that's my presentation about Ezekiel, but I fear that we don't have the fellow. So,
yeah, I
Ariel,
haven't
have you
seen
heard
him join
anything?
yet. No, I haven't heard anything, unfortunately.
We lost Ariel too. Good
Kimmy,
grief.
No, I'm here.
You're on mute, I think.
No, I should be here.
So,
You can't hear me?
So Kim, you did a great
like I said, I
job.
probably should have some jokes here, but I don't know.
Yeah.
We've reached out to him on WhatsApp. It may well be that he just didn't have access to Wi-Fi. But my apologies, folks, that you don't have a chance to actually meet him on the Zoom. This was a little bit of a risk-taking operation. Sometimes these things work and sometimes they don't. So I hope that was informative anyway. And it's not the replacement of the real deal, because he's just a wonderful, wonderful person. And many of you know him very well. And we just all were looking forward to seeing him tonight. So I'm just sorry that he can't be here. But he may have also had an emergency. He's one of the few sophisticated, sort of well-trained doctors where he's up at KCMC. So there might have been a GI bleeder or something, and he always will put his patients before everybody else. So, does anybody have any questions or comments? Or
Kim, thank you for going through that history of the.
I feel like I'm I got to string this out for a while. He might come on, but that's.
Kim can't hear us apparently.
Oh, I think
An Ezekiel
that might
story?
be the problem. Let me reach out to her real quick.
Kim, we're here.
All right. Well,
Kim,
every
wait.
once in a while we have hiccups. So
Kim.
you can blame the Tanzanian Wi-Fi.
Kim, we are talking, but you are not hearing us.
Mike, are you
I'm-
talking? You're on
No,
I'm
mute.
you're-
messaging
Waving
her.
goodbye?
It's you. It's you.
Am I on mute?
Yes. No,
Yeah.
you can't hear us.
I'm on mute.
No.
No.
I can
No,
I'm
no.
on mute here.
No, but you
I
can't
can
hear
hear.
us.
No, your
I
audio.
I can hear, just no.
Kim's audio
no.
is all messed up. Poor Kim. She's missing the
Really?
party.
Seriously? I can't. Can I see? I
I
say
can't see
something
you.
so I can see you.
You're out of focus a bit, but and it's a little dark.
There he is.
There you
Okay.
go.
You're blurry. There you are. Whoop,
I'm
no, there
very. I'm just very sorry because there was a problem with electricity all the night, and I had to travel. I was just trying to make up things to be okay, and I didn't want to disappoint you guys. So very sorry.
Well,
Can you
that's
see
okay.
me
We
now?
understand. I
Yes.
gave you a good introduction. So let's just, in the time that we have remaining here, Ezekiel, let's
Let
why
me
don't you
try-
tell us? Oh,
I'm just trying to look a place where you can see me.
You have a flashlight or something, or it's kind of like,
There you go.
yeah, there we go. Oh, perfect. Oop.
Okay.
Okay. That's pretty good right there.
Okay.
So I want to just, why don't we just dive in? I'll ask you some of the questions I was going to ask you. I've already given the introduction, told the story of you and Judah and you and Stratos, and have a lot of compromising photographs of you. So, and I'll show those to you later. But why don't you just tell us a little bit about how, what you're doing now? Tell us about the Ministry of Neglected Diseases, because I think everybody's fascinated by that. So tell us a little bit about your journey.
Thank you. Thank you, Dr. Shriner. I think everyone is listening me right now when I speak. Can you hear me?
Yes, we can.
Yeah, I am Dr. Ezekiel Moirana. I think most of you knows me. Some of you, they don't know me, but it's really one of the very, very, I don't know how should I put it in English, but one of the journey which I remember when we met with the Phil Simon team. It was in 2004, 2005. I met with Dr. Shriner and the team while I was a clinical officer after just I finished my medical school when I had a diploma in medicine. In Tanzania, you can be school having your 3 years of diploma in medicine, and then you can go 5 years of your medical school to have a medical degree, and then you can continue whether you want to be a resident, a medical specialist, or a fellow, whoever you want. I remember I was working in one of the dispensary which was owned by one of the medical in charge, who was the town city medical officer. He was actually the big boss in the Arusha city. When the team came, I never knew that I would be who I am today. I remember the team came, I was just doing my job as a clinical officer. Dr. Shriner and the team were very, very committed with what they have been doing. And I remember one of the resident, Dr. Christian Stratus. He was working with me, and I was just translating when the patient give the history of what is going on about his health or her health. Those time in Tanzania, we had a lot of patients with HIV/AIDS, and most of the patients, they were not using, there was no ARV, antiretrovirus. What I remember, the team was supporting a lot of things. Instead, along with just attending the patient, but they were coming with a lot of medicine. And the only medicine I remember in my life was the fluconazole. Is it Shriner? That was actually the medicine which was very important in our country. A lot of people had fungal infection. A lot of people had cryptococcal meningitis. And a lot of people had opportunistic infection. And then, I don't know, the team saw this was the important medicine, and then we were actually distributing the medicine. It was really very, very, very unexplainable, because I remember to buy 1 tablet of fluconazole, it costed almost $1 by that time. And then when the medicine came, everyone was telling me, don't give this to patient. We can go and sell for those people who had money. It was really something you cannot do, but sometimes as a human being, some people have to convince you, which I didn't do. but we had a quite large number of patients who were HIV, AIDS, and then I managed to build a team which we could have having their own get together sometimes in a week and then see what we can help them. Anyway, thereafter, when the team get back to America, I remember we were just communicating with Dr. Shriner and the team, and they were, I didn't know what they see to me, but they were just trying to tell me that you need to work in this place. We need these people we need to serve these people. And then I was asking myself, why are they committed? Why do they want to help these people? While we as Tanzanian, we were supposed to be the first to be committed to help our own people. And then I say, okay, I will not look whatever I'm getting, even if I am not get to be paid, but I'll work with these people. After 2 years, was it 2005, 2006, there was a letter. I was just communicating with Dr. Shriner and the other team member. And then there was only one email which I remember in my life. It was an email which was, it give you all you want. It was just, what do you want us to help us? I need you to write, it was 2 pages of a paper. Tell me, what do you want? And why do you want us to help us? And why do you think you deserve to get this? I was not good in English, and then I was asking someone, hey, I don't know how should I answer this question. Say, okay, you just write in Swahili and then I can translate to you. And then I have to write. I think it was only the letter which me and Dr. Shriner have an answer why I am today. I don't know why did they supported me. I don't know why did they pick me to be part of the Phil Simon, but I think that the letter which they have actually, Dr. Shriner and the team can explain to everyone here, why did she pick me? Why am I deserved to be who I am today? Having said that, I got a chance to go to medical school in International Medical Technological Medical School in IMTU in Dar es Salaam. The Phil Simon Clinic Tanzania project support me in everything. I was just in school. I was just doing my schooling and nothing else. They were paying my school. They've been paying my pocket money. They've been saving my family with my late mother. And I have never went through any difficulties during I was in my school. Everyone who I have been schooling with them, they saw me like I was a son of the richest man, but I never behaved like that. But they never saw me saying, you see, sometimes, well, you didn't pay school fees, you didn't pay this, but that was how was my life. But I grew in a very, in a family of 11 children. I'm the 11th young boy, the last one who was born with my late father. And now I can speak my late mother who died just 1 year ago. My mom was a hero in my life. She did a lot to me, like the Phil Simon has done to me. She grew up with all the difficulties with me, and she was always telling me that you will be one of the best man in this world and you go to school. She have never been in school, but she know how important someone to be in school. I'm sorry. Anyway, thank you. After I did my school, my first degree of medical school, I was the best student in school. when I did my graduation, I was offered with a Phil Simon to visit Zanzibar. That was my first time being in Zanzibar with my family, my wife, Jessica, and my children. And then when the medical school saw me that I'm just finishing, and then I remember the principal of the school and the vice chancellor called me, and then they offered me to do my residence because I contributed. They think I contributed at the end. Actually, it's not me. It was the Phil Simon. They think I contributed to the school. I remember in 2007, the Phil Simon Tanzania project donated a 10-headed microscope in the lab, which in Tanzania, it costed almost, I remember those days, it was like 60,000, 80,000 US dollar when you have to buy. And then the university became the first university to own the 10-headed microscopy. And that's where, and then the other year, the Phil Simon donated an Olympus, a brand new Olympus endoscopy, which I didn't know the price by that time, but now I can speak of how much it cost to have to own a microscope, because I'm a fellow gastro right now speaking. And then the vice chancellor just told me, you know, we need you. And I think the university is ready to offer you to do your residence. In Tanzania, you have to pay the residence. So they just gave me an offer of paying half of the school fees, and then the school will pay half of my school fees to do my residence. I spoken with the Phil Simon team, Dr. Shriner, and I told her, she couldn't stop me. She said, there's nothing you have to do. You just keep going, go for your school. We will pay for the rest of your fee. And then it took me 4 years to graduate to do my internal medicine residence. And then after that, I started working under the government, where I just posted in Dodoma, one of the new, which is actually a tertiary hospital, Benjamin Mkapa Hospital. I worked in since 2016 to 2018. And then 2019, I met with one of the professor in Tanzania, who is an Italian professor. His name is Professor Costamagna. We just worked like 2 weeks, and then he was training me an endoscopy. He said, I think you can do something to your patient. I remember one of the patients was vomiting blood a lot, and then he couldn't like, and he said, you need to know this. And then I told him, you need to teach me. I'm ready to work with that. And then he showed me how to do a diagnostic endoscopy. It took only like a week. The other week when he gave me an endoscopy, it was easy for me just to go easily. And then he said, you know, I'm going to Italy, then I'll call you back. They offered me to do a fellow in Gemelli Hospital, Rome, Italy. And I know Dr. Shriner was so surprised when I told her. I said, she told me, you know, I think you deserve it. Anyone who sees you will just give it to you. And then I say, why will they have to give it to me? Say, because you know, anyway, it was just a long, long story between me and Dr. Shriner. I finished my fellowship 1 year in Italy. I came back in Tanzania. I started working, and you know, unfortunately in our country, we work different as how you guys work. Sometimes when you are committed to do something, people will give you some other activity. They believe that you can only do everything because you are someone else anymore. Back to who I am, what am I doing right now? I was appointed in the Ministry of Health to work as a program officer. In Tanzania, we have different programs. We have the malaria program, the National AIDS Control Program, and then we have the TB and leprosy program, and also we have the neglected tropical disease program, which actually in malaria, we know how malaria is really killing a lot of people in Africa and all over the world. That's why the ministry have put the program, these are just like, and to highlight and to concentrate as one of the big issue among the society, and choose the focal persons who actually have to concentrate, supervise, work together with all lower level, like a district, regional district, and make sure that we are bringing this disease from the high prevalence to the lower prevalence, and if possible, we need to control as well as the elimination stage. So for the neglected tropical disease, we have about 6 diseases which we are supervising. Speaking of that, we are supervising helminthes, all helminths, all the ascaris, hookworm, and all whatever we speak of helminths in children. This is where my program is actually supervising. We have a lot of ascaris, ascariasis, a lot of hookworm manifestation, and all other helminths, even the Taenia solium. We have a lot of them in our country. And also another disease which we supervise is schistosomiasis, which is very, very almost covering all the cancers initially. The baseline speak about 184 cancers or districts where have a high prevalence of schistosomiasis. But currently, we actually drop up the prevalence of the disease up to, we are speaking of 9 to 11 cancers only. We are actually ending toward to elimination of schistosomiasis. Another disease which we are actually supervising, this is what I'm actually working as a focal person, is onchocerciasis. Onchocerciasis is actually a disease which is covering most of the regions, like 7 regions. We have Morogoro, Tanga, we have Mbeya, Iringa, as well as Ruvuma. This and Songwe, these regions, we have about 29 cancers whereby a lot of people have this disease. And now the Ministry of Health is trying to work. You know, I'm speaking right now, I'm not in Dodoma, I'm not in Arusha, I'm just in Tanga. I just arrived in Tanga, in where the area is highly infected with onchocerciasis, in a place known as Kilindi. I'm supervising, we are doing actually elimination, I mean, what we call it, OEM, onchocerciasis elimination mapping. We are taking blood sample in children of aged 5 to 9 years and taking to the national lab to do, because confirming onchocerciasis is very expensive. You need to do OV16 test, and then you have to confirm by doing a PCR test to know whether there is infection among this village which are living along the river in this society. Having said that, another disease which we actually supporting is lymphatic filariasis, and also we have the rabies, we have the other, but neglected tropical disease are many in our country. But now the Ministry of Health is only supporting about 6 diseases together with trachoma, which is very, very common in our Maasai people, nomadic people. So in Ngorongoro, Simanjiro, and all other place. I've been working every day, going there because of trachoma. And actually, to be honest, one of the things which made me to be part of a NTD, neglected tropical disease, is trachoma. I thought I can go back to my society and try to participate on elimination of that disease. So as I said, I'm a program officer and I'm working under the Ministry of Health. My duty responsibility is to work together with the program manager and all other program officers, going to the district supervising and make sure all the society are covered with mass drug administration, which we normally distribute. We give them like ivermectin, we provide the praziquantel, and we provide azithromycin for those who have trachoma, as well as those who have schistosomiasis and those who have onchocerciasis. So we have a lot of duties which we do, and we normally do twice in a year. But apart from working under the ministry, I'm also practicing as a physician, and I'm doing my daily activities. When I get back to my center, I normally have my private place where I go to practice and see patients and do some colonoscopy, doing some gastroscopy, and also I have to do some interventional gastroscopy, like doing band ligation, and sometimes I do polypectomy. Well, this is who I am today. And the Phil Simon raised me when I was down, and now I am who I am. And I think the Phil Simon is not doing just a small job. It has done a lot of job. We saved a lot of people. We touched a lot of people's life. I cannot explain how many, but I remember when we have been doing home-based care with Judy and Tom and the other team. I remember how many people who we touched their life. The HIV community, the stigma life, those days was unexplainable. Speaking of my country today, the Phil Simon have done a lot. It actually coached a lot of people, hundreds of medical personnel who actually applied the education to the society. And now we speak of HIV, we speak of stigma within the community. It's not really as it was. And thank you. I think I will speak when the questions come. That is it. I'm sorry. I'm very, very sorry for being late to be a part of this.
It was worth the wait. It's amazing, Ezekiel. You're just such an amazing person. And I think it just is so inspiring for all of us, what you do and what you've continued to do. And what do you think are the biggest challenges going forward? You're now in a department with incredibly important diseases, and I was kind of in the chat explaining a little bit of what some of these parasitic diseases are. But what do you think, in addition to infectious diseases and of course HIV, what do you think are the other big challenges in healthcare in Tanzania?
Well, I will say that actually HIV is still a big problem, but with the presence of ARVs, there's really a big difference right now. You know, those days when we see someone with HIV who is infected and the family which was affected, it was really different as comparing right now. I remember those days, you just keep praying, going to church, and people are crying, and everyone see you like you are a dying person, not like what we see right now. We have actually moved to another state. There is a lot of acceptance of being HIV AIDS infected or HIV infected and living the normal life and doing your daily activities, and stigma among of those HIV infected people have actually reduced. The other thing is that the Ministry of Health have been working together hand to hand with the society. I know we have a lot of, we are actually living in a pool of infectious disease. We cannot say that we are good, but we can only say that we actually moved to a high rate, maybe to a moderate. We'll speak of that. But we are lacking a lot of medical personnel. And apart from that, we have some of them who are not even yet employed, but sometimes the government budget cannot actually fit to employ this medical staff. If we speak of the doctor to patient ratio, it's very high. But how can we accommodate those people who are not working as medical personnel? That's another issue. So we have some people who we think we can involve them in our place, but we don't have the budget to involve them. Most of the medical personnel are now seeking a lot of volunteering job rather than being employed. This is actually shocked me because I remember when I was a clinic officer, we met with a team. I knew that when I get my medical degree, I will be just employed because there was a very high need of someone who own a medical degree. But now I see some young medical doctor, no employment, they have their medical degree. And then I started to think, oh, only 10, 20 years, things have changed like this. So we need medical personnel. We need to eliminate the disease. We need to stick on control a program of the diseases. And also we need to educate a lot of medical staff. That's the most important, I think we have to engage ourselves. Talking of the policy of the government, well, I am not a politician. I cannot speak on that, Dr. Shriner. But if I will get a chance to advise, I'll speak of increasing the high number of people who are going to medical school and making sure that at least we reduce the doctor to patient ratio. I now can speak how big the problem is because I'm traveling from the right now I'm in Kilindi, it's one of the districts. I go to the villages. I see how the dispensary is there, but and health center is there, but you find sometimes a nurse is only saving all the population. So we need medical people. We need medical staff.
It's it's certainly one drop at a time, but those drops can have a lot of ripples. One of the things we're noticing, Ezekiel, around the world is that as populations move from rural areas or agrarian areas or even wild areas, for example, the Maasai and your Maasai in Africa, one of our studies, and Dr. Mattioli, who's on the meeting tonight, did this study and was actually presented in Rome, actually, a few years later, looking at the transition of people moving to urban areas where their diet changes. So it goes from largely plant and protein-based diet to carbohydrate diet. And really one of the significant diseases we're seeing in many, many parts of the world now, as that happens as people go to the cities to find work, is the emergence of a high amount of diabetes and hypertension. And so is that something that you've been seeing as well in your populations, that in the cities that when you're treating patients?
Yeah, thank you, Dr. Shriner. I think there is a very high prevalence of non-communicable disease right now, which is actually rising in our country. And I just remember last 2 weeks, the Ministry of Health have actually identified an office I just appointed one of my fellow physicians to be the director of who was the director of curative services, to be the director of non-communicable disease. We have quite a large number of diabetic mellitus, especially type 2 diabetes. It's really very common. We have a high number of hypertensive heart diseases. We have a very, very rise up of chronic renal disease. A lot of dialysis centers now have been introduced in referral hospital. And I don't know why, but the reason you are giving right now, it's really quite important, because we see people have changed, enjoying their quiet life of taking natural food, and people are just living the sedentary life. And also, I am a Maasai, but the natural food of Maasai is not what now most of the Maasai are taking, you see. And also with the high consumption of salt, less exercise, and a lot of things are raising up. But initially, what they have been speaking with the chronic renal disease, they've been speaking about issues with the antiretrovirals, especially the tenofovir and the other drugs, but not really the one which is causing now. Because I remember last week I visited one of the referral hospital, and I noticed the dialysis center, the machine, they had like 16 machines, and 2 of them were just isolated for those people who are infected hepatitis B and HIV to be using. But I found the other 14 machine, it's just be used with most of the people who are diabetic hypertensive patient. So you can see, if now you come to Tanzania, almost all regional hospital, even Mount Meru, and all the regional hospital, the government have just equipped the dialysis machine because of the CKD, chronic kidney disease, which are actually caused by the chronic diseases, non-communicable diseases like diabetes and hypertension.
Yeah, it's a similar problem in the United States. It is encouraging now that Tanzania has access to dialysis, because I can remember the first few years when we were there, if your kidneys failed and you didn't have a lot of money to go outside the country, it was kind of the end of the road. And what you were talking about, Ezekiel, just for our audience, is that one of the antiretrovirals contains a medication that can, for long-term use, can sometimes cause kidney problems. But it's probably not the leading cause of kidney disease around the world, which is more diabetes and hypertension and so forth. So, well, I think this has been, you came on just in the nick of time. I was running out of things to say to keep the audience interested, but we are so glad that we were able to pull this together. So you're actually in Tonga right now, is that right?
What?
You're in Tonga, the district of Tonga?
Yes, I'm just in Tonga, guys, and I have my team over here. You can see some cars down there.
Can't sort of blurry.
Oh, sorry.
That's okay.
There's some cars outside there, which we have. I have a team of lab technicians, about 15 of them. And then I have the research assistants who they are going to fill the questionnaires and take the GPS of house to house. We will be visiting 30 villages, 15 in this place. And then we go to another place known as Handeni. We take 15 villages. We go house to house. The team will be just house to house and take the DBS, we call it dried, the lab techs knows the DBS when I say, and then we send this sample to the national lab for the OV16 test for onchocerciasis. And then if we get more than 2% of the population, the sampling technique, it's about 100 sample in each village. That's the technique, actually, the sampling technique. 100 in aged 5 to 9 years, 100 children, and then we send them. We expect to get 3,000 samples from 30 villages, each village 100 children of age of 5 to 9. We send to the lab when it is positive, when it actually consider the whole population which we took this sample. And then if the sample came up to be positive for more than 2%, we will come to do to start with a sensitization to the society, starting the mass drug administration, specifically the ivermectin drug. And then after that, after 5, you know, one of the issues with onchocerciasis is that the Simulium damnosum, which actually infect human being by having Onchocercus volvulus, is that someone can survive with the Onchocercus volvulus within the body, can be one of the reservoir in the human body, and it can stay in the body for 15 years. So you can find that you need to do an annual MDA, giving the drugs every year, and then you have to retest after to make sure that you bring the prevalence of the disease to less than 1%, and then you go to elimination stage.
Right, so are they they're not doing skin snips anymore, Ezekiel, for onchocerciasis?
We could have to do, but it's really very expensive. This is what we
the dry blood samples, that makes more sense. Yeah.
Yes, it is very expensive. Now, right now, we just know we do the serology. When we know that, you know, that someone who is positive with the serology, it doesn't actually tell you that he's still having the onchocercus. It just shows you that someone has been exposed. But the PCR is the one which actually pick up this is there is actually ongoing infection. We decide to take the children of 5 to 9 years, because if I take an adult who have been exposed in 20 years ago, I'm not actually confirming that this person have a disease. But if I take a child of 5 years to 9, I know in the past 5 to 9 years, still there is a simulium which have actually bitten these children, and possibility of ongoing infection, ongoing transmission to be in this society is high.
Right. Well, this is a good example of where a little bit of technology, such as PCR technology, which is become much more accessible to underserved countries, can make an enormous difference in a disease like onchocerciasis, which is one of the leading causes of blindness and other problems in Africa. So, gosh, I mean, we could really get into the weeds, you and I, about all of this, but I think the rest of the audience probably doesn't want to hear about the parasites of Africa as much. So I think this requires another visit from you at some point. And we are just so delighted that we were able to connect and have you on, because you are just a rock star, Ezekiel. You are the firstborn, but also just a magnificent inspiration to your patients and to the people that you work with, and to your family and to all of us. And we thank you so much for what you've done. So
I think I may need another interview because of my time, and with a shortage of electricity, we can figure another interview. I can see Laura, I can see Audrey, Lauren, I see a lot of people, Steve, but I see also Judy. I don't see Tom. I don't see some other people.
Tommy, I think he had something to do tonight, but he was,
okay.
You've got a big good turnout.
All in all, I will say, Dr. Shriner, that what the Phil Simon is doing, it should have to continue to do. I can say who I was, not who I am today. And I always wish everyone to be touched the way I have been in my life.
Well, for the audience, you helped select one of our next scholars as well. I know, I think it's Veronica was it Veronica that you got hooked up with us?
Yes.
Yeah,
yes,
so that's one of our social work students.
I met with Veronica when I was doing my clinical medicine. I was practicing as a physician, and Veronica was just the sweeper in the office, helping organizing the clinic. And then I remember I asked her one question. I asked, "You are too young. Why are you doing that?" And she couldn't respond to me. And then the other day I asked you, "Where is your home? Where is your parents living?" It was a touching question, and she was crying. And I say, then I took her to my office. I say, "I need to know, why are you crying? I asked you just a normal question." She said her father died when she was very young. She was raised with her auntie. Her mother died. She only remembered that her mother died of tuberculosis. And then, but I guess it was HIV/AIDS because of the story, and I have to go back to know what was going on. And then she have her other young 2 sisters who are depending on her. And I told her, "Okay, so how are you managing to take care of this family?" And it was really an tough issues to ask you on her. But after that, I just, when the Phil Simon told me that this form, this is going to be to other people, I thought, but I think we are looking people who need to serve the people and who are committed. And then I asked her, "Who do you want to be?" She said, "I want to be a nurse or a social worker." And then I say, I think in my heart, I think she deserved to be a part of the Phil Simon. So I gave her the form. I said, "You need to fill this. I don't know. I cannot promise you anything. If they will accept you, then you will go to school. But if you don't want to go to school, don't fill it. And if you don't want to become someone else." And then when she filled, I just spoken with the Phil Simon one day. I say, "There is someone who I saw. I think it was someone who can be someone in the society." That is it. And actually, if you ask Dr. Shriner, how did she know herself? So I'm so happy to see now she's a part of the Phil Simon, just like Rebecca. Because I remember when we were working in Kizongo clinics, and then there was a lot of clinical officers, but Rebecca was very, very, very active, very committed, hardworking, without even knowing who I am. I never knew her. And just my first time. And then Dr. Shriner asked me, "Who do you see this stuff? Who do you think we should consider?" I just told her, "I think this lady Rebecca deserves. I think she's very committed and always happy to do whatever you ask her to do." So that is it.
Well, the legacy lives on, and even though these are small drops in the bucket, they make an enormous difference. And so I just want to thank you, Ezekiel, for taking the time out. It sounds like you're very busy. Get back to your village and doing the patient research. And I want to thank our audience for being patient with our technological issues. But I think it was very, very powerful, and just, you're such a wonderful spokesperson for the project and for what you've accomplished. You should, we're all very, very proud of you, and you're just an amazing person. So I think that our project is small, but if you don't think that small things can make a big difference, try spending time in the room with the mosquito.
You are absolutely right, Dr. Shriner. And I think the small things make a lot of things to move on. And I was a clinic officer, and now I'm a program officer. I was touching people in the level of a very small community. Now I'm touching people in the very large community, overseeing my country at the high top level, knowing all the regions, seeing what should I do to the people of Tanga, to the people of Morogoro, of Arusha. This is how the Phil Simon have been growing people from down to the top. And I remember you said, if you want to go fast, you do what?
Go alone.
If you want to go far,
You go together.
we go together. And this is what I mean when we speak of going together. There are a lot of the Phil Simon team who were committed. I remember the team which started is not the team which we have right now, but still the team which started is still there. It started with how many, Dr. Shriner? Because I was not the first.
7. Yeah.
7. And then the other year came up with 12, I guess.
Yeah. Last team was 61.
Is 61. And hopefully the last team will be a millions number of people who are saving the society.
Well, you can make that happen, Ezekiel. So I'd like to thank everybody tonight for sticking on and really being hopefully inspired. We appreciate all of your support. Look forward to our next speaker. We'll definitely have Ezekiel back, and he and I can talk about worms all night long. So, but I thank everybody tonight and have a wonderful weekend. Ezekiel, be safe. Don't get onchocerciasis yourself. Watch out for those little chameleons there. And we'll see everybody soon.
Thank you so much.
Okay.
I hope everything is going to be okay, and I'm looking forward to see you back. And I'm organizing next trip. I know I have a lot to do, and since I'm now working with the ministry, things will be more smoother not as it used to be, Dr. Shriner.
We will see you very soon. You and I'll be talking next week, I'm sure, Ezekiel. So say
I love
hello
you
to the
so
family.
much, everyone, and say hello to everyone in the family. And I wish you all the best. Just know that whatever you are doing, you're not doing something which is small. You are doing a lot of job. You are saving a lot of people, and people who you never even met with them. And people are just saying thank you to you.
All righty. Safe travels. We'll see everybody
Bye-bye.
later.